Welcome everyone. Today we're going to take a journey into the living biology of orthodontics. Whenever you place a bracket, bend a wire, or activate a spring, you are not just moving teeth through bone. You are triggering a cascade of biologic events that involve the gingiva, the periodontal ligament, the cementum, and the alveolar bone. And if you go further with orthopedic forces, you're even asking sutures and the temporomandibular joint to adapt. Our goal today is simple. By the end of this lecture, you will understand how tissues react to orthodontic forces at the cellular and histologic level, and you will be able to translate that understanding into safer, more predictable clinical mechanics. So let's begin with the tissues of the periodontium. First, the gingiva. Think of the gingiva as the protective seal around the tooth. It's not just pink gums for show. It's a carefully engineered cuff that prevents bacteria and trauma from penetrating deeper structures. We divide it into free gingiva, that delicate rim hugging the enamel, and attached gingiva, which is firmly anchored to the alveolar bone. The attached gingiva is like a strong gasket, resisting the pull of muscles and trauma. Its collagen fibers run in several important patterns: circular fibers wrapping the tooth like a belt, dentogingival fibers attaching the gingiva to the tooth, dentoperiosteal fibers that link the tooth to the periosteum, and transeptal fibers that span between adjacent teeth like guy wires. Why do we care clinically? Because gingival phenotype matters. Thin, delicate gingiva doesn't tolerate labial movement well. If you move an incisor labially through thin tissue, you risk both inflammation and recession, especially if the patient's plaque control is poor. This is why, before you start labial expansion in a thin biotype, you need to consider augmenting keratinized tissue, reinforcing hygiene, and above all, moving slowly and gently. Now, the periodontal ligament. If the gingiva is the seal, the PDL is the living suspension bridge. It's only about 1/4 millimeter thick, but it's packed with cells, vessels, and nerve endings. It functions as a shock absorber, transmitting and moderating the forces we apply. It also acts as a sensor. When you chew, the PDL tells your brain exactly how much force you are applying. That's why a tooth with a healthy PDL can feel a hair strand between your teeth, while an implant, which lacks a PDL, cannot. The fibers of the PDL are organized into groups: alveolar crest fibers that resist extrusion, horizontal fibers that stabilize the tooth, oblique fibers that bear most of the occlusal load, apical fibers that resist luxation, and interradicular fibers in multi-rooted teeth. When we apply orthodontic force, the PDL is the first tissue to feel the pressure. Fibroblasts remodel collagen quickly. Blood vessels constrict on the pressure side and dilate on the tension side, and nerve endings contribute to the discomfort patients feel after an adjustment. Next, the cementum. Cementum covers the root surface. Unlike bone, it is avascular and does not remodel physiologically. It's continuously deposited, especially in the apical region, to maintain the attachment of Sharpie's fibers. Think of it as the armor plate of the root. It is remarkably resistant to resorption, more so than bone, but it is not indestructible. Excessive or prolonged pressure can expose cementum to clastic activity, leading to root resorption. Finally, the alveolar bone. The socket walls are made of cortical bone, backed by cancellous bone. Osteoblasts build, osteoclasts resorb. Under orthodontic force, tension stimulates deposition, pressure stimulates resorption. Importantly, the body does not physically push teeth through bone. Rather, it removes bone in the direction of movement and rebuilds it behind the tooth. This distinction is critical. If you push too far beyond the bony housing, especially in thin labial plates like those of the lower incisors, you risk dehiscence and fenestration, essentially pushing the root out of its skeletal envelope. That completes our anatomy refresher. Gingiva as the seal, PDL as the suspension bridge, cementum as the armor, and bone as the dynamic frame. Keep these images in mind, because every reaction we describe from now on is simply a variation on how these tissues cope with load. Physiologic migration and initial response to force. Now, before we discuss braces and wires, let's look at what happens naturally. Teeth are not static. Molars tend to drift mesially, incisors migrate if neighbors are lost. This is physiologic migration. Even without orthodontic appliances, bone and PDL remodel constantly in response to everyday occlusal forces. When a tooth migrates physiologically, the pressure side undergoes bone resorption. The tension side sees bone deposition. The PDL fibers reorganize, old Sharpie's fibers become embedded in new bone, and cementum adds new layers at the root. This natural migration shows us that orthodontic movement is not an artificial trick. It is simply controlled acceleration of a natural biologic process. Now, what happens when we apply orthodontic force? Forces can be continuous, interrupted, or intermittent. Continuous forces, like those from arch wires, maintain a steady load until the wire deactivates. Interrupted forces, like coil springs, gradually decay but maintain some continuity. Intermittent forces, like removable appliances, act only when the patient wears them. When we first load a tooth, several things occur almost immediately. Fluid shifts in the PDL. On the pressure side, blood flow decreases. On the tension side, it increases. This vascular change alters cellular activity. Within 30 to 40 hours, osteoclast precursors appear. If the force is gentle and within physiologic limits, bone resorption begins directly at the alveolar wall. This is called frontal resorption. But if the force is too heavy, circulation is cut off entirely in that segment of the PDL. Cells die, leaving a glassy acellular zone known as hyalinization. In this case, movement halts until macrophages remove the necrotic tissue and osteoclasts resorb bone indirectly from adjacent marrow spaces. That is undermining resorption. Here's a useful analogy. Gentle force is like slowly opening a gate. The gate swings smoothly on its hinges. Heavy force is like slamming the gate shut. The hinges jam, debris builds up, and you need workers to clear it before the gate can move again. This is why light, continuous forces are almost always superior to heavy, intermittent ones. They keep biology moving smoothly instead of stalling it in cycles of necrosis and repair. Hyalinization, root resorption and repair. When pressure is excessive and hyalinization occurs, the PDL in that area becomes cell-free and glassy under the microscope. 3 stages follow: degeneration of local cells, cleanup by macrophages and osteoclasts, and eventual reattachment of fibers as repair begins. Clinically, hyalinization explains why a tooth often feels loose or sore a few days after adjustment. The PDL is not functioning normally. In young patients, small hyalinized zones may resolve in 2 to 4 weeks. In adults with denser bone, it takes longer. But the real risk is root resorption. When clastic cells clear necrotic tissue, they may attack cementum if it is exposed. They create resorption lacunae, small pits on the root surface. In most cases, these are microscopic and later repaired by cementoblasts. But repeated trauma or uncontrolled forces can make resorption progressive and irreversible. Which movements are riskiest? Intrusion is number 1. Think of it, the entire force is concentrated at the apex, a tiny area of the root. Uncontrolled tipping is another, because one corner of the root bears most of the compression. Both situations concentrate stress where cementum is least forgiving. Clinically, the rule is use feather-like forces for intrusion, distribute load when possible, and never reactivate aggressively into a tooth that is still sore. Respect the biology's recovery window. Types of tooth movements and tissue risks. Let's examine each type of movement. Tipping is the simplest. It's force efficient but creates 2 zones of compression and tension, one at the crest, one at the apex. That means short hyalinization periods but increased risk of localized root resorption. Torque, or root movement, moves the root while crown position stays stable. It demands precise couples of force. Risks? Pushing roots through thin buccal plates can cause fenestrations and gingival recession. Bodily movement, or translation, requires 2 equal and opposite forces. Load is distributed evenly across the PDL, making it biologically gentle, but it requires higher magnitude of force to achieve. Rotation twists a tooth around its long axis. It creates 2 pressure and 2 tension zones. Fibers are severely displaced, especially transeptal fibers. That is why relapse is notorious after rotations. Overcorrection and sometimes circumferential supracrestal fibrotomy are required. Extrusion stretches PDL fibers and primarily creates tension. It is biologically safer, but heavy forces risk pulling the tooth out of its socket. Intrusion is the red flag. It concentrates force at the apex, making it the highest risk movement for root resorption. Only 10 to 20 centinewtons per incisor should be used, distributed across several teeth when possible, ideally with TAD support. The other dimension is direction. When you move roots labially or buccally beyond alveolar housing, the bone does not magically remodel to accommodate them. Instead, you risk dehiscence and gingival recession, particularly in thin gingival biotypes. This is why CBCT assessment and respect for the alveolar envelope are so important in treatment planning. Sutures, TMJ, stability, and relapse. Orthodontic forces act on the PDL. Orthopedic forces act on sutures and basal bone. Let's start with sutures. The mid-palatal suture in children is broad and relatively straight, under transverse force. An initial catabolic phase occurs. Osteoclasts resorb interdigitations, loosening the suture. Then comes an anabolic phase. Osteoblasts lay down bone to fill the gap. This is why retention after rapid maxillary expansion is essential. You need 4 to 6 months for new bone to consolidate. In adolescents and adults, sutures become interdigitated like puzzle pieces. Expansion becomes less skeletal, more dental. That is why MARP or SARP are needed in older patients. The temporomandibular joint also adapts under orthopedic loading. Functional appliances shift mandibular posture. Studies show condylar remodeling in many patients, forward seating, changes in volume, adaptation of articular surfaces. But results are variable. Not every patient remodels predictably. Therefore, monitor TMJ carefully during orthopedic therapy. Now, stability. At the end of treatment, teeth don't just freeze in place. Collagen fibers recoil. Bone remodeling lags behind. Transeptal fibers in particular tend to pull rotated teeth back toward their original position. This is why relapse is common, especially after rotations and expansions. Retention is not optional. It is the biologic requirement for tissues to reorganize. In some cases, surgical fibrotomy or overcorrection is needed to reduce relapse risk. But the key takeaway is that retention is not just about discipline, it is about giving biology time to catch up. Let's bring it all together. Every orthodontic force creates a biologic response. Gingiva seals, PDL senses, cementum anchors, bone remodels. Light, continuous forces create smooth frontal resorption. Heavy, careless forces create hyalinization and root resorption. Each type of movement carries risks: tipping risks, localized resorption, torque risks, fenestrations, rotation risks, relapse, extrusion risks, periodontal compromise, and intrusion carries the greatest resorption danger of all. Orthopedic forces work at the level of sutures and joints. Sutures can be opened in youth, but need surgery or skeletal anchorage in adults. The TMJ may remodel under functional loading, but results are variable. Finally, stability is about biology. Retention is mandatory because fibers recoil, bone remodels slowly, and biology resists permanent change. So here is the one-sentence rule. If the capillaries are happy, the biology is happy, and teeth will move as you intend. Design your forces for cells, not just for steel. Thank you for joining this lecture. I hope this gives you a clearer, deeper, and clinically useful understanding of tissue reactions in orthodontics. With this knowledge, you can practice with greater confidence, safer forces, and more stable results.